Professor of Ophthalmology at RP Center with me, and a very prolific retina surgeon, and Dr. Shaurya, additional professor of ophthalmology and also retina surgeon at RP Center. So we would be talking today about retinitis. So retinitis is a condition which can be really devastating and can lead to loss of vision, and it's important that all of us know how to recognize it and timely treat it. So we'll be talking of some of these aspects. So I welcome Dr. Nawazish. Dr. Nawazish is also assistant professor now with us at RP Center, and she'll first introduce the topic and tell you how do you know that you are actually dealing with something like retinitis. Dr. Nawazish, please.
Slides. So good morning everyone. As Sir rightly pointed out, that retinitis, unlike other forms of uveitis, is important to be diagnosed. They are more commonly infectious in nature. So how do I know I'm dealing with a case of retinitis? There can be some specific scenarios that we come across in a clinical practice. A patient may come to us just with some complaints of blurring and floaters, and on fundus examination, anterior segment examination, we see there's some AC inflammation, few cells flare, RL cells are present. When we're doing a fundus examination, we're seeing that there's some vitritis, and we look in the periphery and we see these areas of retinal whitening, such as this case, which was a case of acute retinal necrosis. Another thing is, so once we have these things, we need to identify at what level is this retinitis. It could be full thickness or involving the inner retinal layers, or it could be outer retinal. Now, the beauty of the retina is such that these blood vessels are present in the nerve fiber layer. So anything that is deeper to the nerve fiber layer, the blood vessels would not be obscured. However, anything that is involving the inner retina, the blood vessels would be obscured. So accordingly, we have this patient, which was a case of syphilitic retinitis. As you can see, there is a white patch at the posterior pole. The areas of the margins are fuzzy, and at two places, at one place you can see the blood vessel properly, whereas at the other area you cannot see the blood vessel. Similarly, this was a case of focal toxoplasma retinitis, in which on OCT you can see involvement of all the retinal layers. Whereas if the outer retina is involved, the blood vessels are intact. You can see them going above the vessel properly. You can trace them from the beginning to the end, and you can see this white patch in the deep retina. Another scenario that can be is that they have significant vitritis. In such cases, we can either see a patch of retinitis at the posterior pole, giving the first image, that would be the headlight and fog appearance, or the posterior pole is relatively normal, but we look in the periphery, or we examine the periphery, especially the temporal periphery, and we see this area, white discrete area through the vitritis, as a case of acute retinal necrosis. Sometimes they may present looking similar to cotton wool spots, or such as this case of post-fever retinitis. At this point, I would like to point out they need to be differentiated with normal cotton wool spots that we see. So if you can see the difference between these two images, the cotton wool spots over here are associated with overlying inflammation, some thickening of the retina. There is presence of fluid or cystic change at the macula. There can be associated hyperemia, whereas in this image, you can see the cotton wool spots are well demarcated. There is some amount of hemorrhage, so this was a case of macular BRVO vis-a-vis a case of post-fever retinitis. Then there can be presence of focal retinitis in Behçet's disease. So the right eye of the patient has dense vitritis, but at the posterior pole you can see some amount of retinitis, whereas in the left eye we can see these focal areas of retinitis, and an OCT through this shows a full thickness involvement of the retina. Then diffuse retinitis, such as a case of CMV retinitis. So the difference in these patients is that the posterior pole is commonly involved. It is associated with hemorrhages. Image on the right-hand side is of granular type of CMV, whereas on the left-hand side you can see a predominant frosted branch appearance of CMV retinitis. The third scenario would be presentation at an unexpected age with a exudative retinal detachment or a retinal detachment having very posterior retinal breaks, such as this 8-year-old who presented to us with this image. He was started immediately on antivirals, and on day 7 there was reduction in his exudative retinal detachment. At the same time, you can see clearly the peripheral area of retinal necrosis. We need to differentiate these patients with choroiditis. So because choroiditis is deeper, it is more yellow. So the more deeper we go, the more yellowish the lesion becomes. So we did an OCT through this, and we can see that there is thickening of the choroid at this area. So this was a case of focal choroiditis. But not all whitening is retinitis. There can be other differentials to these patients, such as, for example, on the image on the right is a case of Schwarzma syndrome, and that is myelinated nerve fibers and not a case of retinitis. And on the left, you can see partial retinopathy. Again, there is retinal whitening, but there is no associated inflammation in this case. Again, on the right-hand side, there's fibrosis at the subretinal level, but not a case of retinitis, no inflammation. On the left-hand side, there is old vitreous hemorrhage. We cannot see the vessels underlying it, not a case of retinitis. And this case, for example, you can see some yellowish lesion at the posterior pole. There is presence of an inferior exudative retinal detachment. You see in his left eye, there's a small yellowish lesion at the posterior pole. But if you look closely, there is a gravitational tract present in his left eye. So this was a case of CSC. Not all macular exudation can be a part of retinitis. This was a case of Coates disease. You can see the telangiectatic aneurysms at the posterior pole. So my take-home message is that whenever you see any obvious white areas in the retina, please look for signs of ocular inflammation. It could be just a few KPs, few anterior chamber cells, few RL cells, but do go ahead, give a good slit lamp examination to these patients. You see hazy media or vitritis, do a good peripheral examination. At times you may see areas of peripheral necrosis of the retina, which would indicate it is ARN. And if you see a cotton wool spot appearance, so cotton wool spot associated with macular exudation with disc hyperemia, again, look for signs of inflammation. Patients with malignant hypertension can have similar findings, but there will be no vitreous cells on OCT, no anterior chamber or RL cells. And whenever we have patients who present in an unexpected age group, large posterior breaks, sieve-like breaks, please do go ahead and think of retinitis as a differential before thinking of anything else. Thank you.
Thank you so much. So she has talked about general about retinitis and some causes. Causes we would be going in detail in the subsequent talks. But the most important message which goes out from this is that first of all, see if the eye has some signs of inflammation or not. So if there are some signs of inflammation in form of anterior chamber cells, retrolental cells, vitritis, disc edema, some engorgement of the veins, you feel there is some inflammation in the sign in the eye, then if there is a white area there, very high probability that you are dealing with retinitis. Just an isolated white patch like he showed could be something else also. And very importantly, she has mentioned it, but please remember, if cotton wool spots are there, hard exudates are there, disc edema is there, bilateral, number one, do not say it is post-fever retinitis. Number one, yes, get a blood pressure checked. So that is one mistake I've seen, even I have made it once. So first of all, hypertensive retinopathy becomes the first diagnosis, unless, yes, obviously there is some signs of inflammation also in that eye. So the other things also need to be ruled out, but yes, if there is inflammation, there are white patches, and sometimes the inflammation will be so marked that you may not see the white patch. Then be very careful, definitely move your gaze towards the temporal retina. If there are white patches there, then it might be retinitis underneath. And rather than just giving steroids blindly, you might first give a thought of adding antivirals first. So you have to be very careful, rule out retinitis for these infective causes. Dr. Vinod, you would like to add something?
Very well highlighted, Nawajish. I think you mentioned it, but I'll just re-emphasize on that. That whenever you have inflammation, remember everything we see would come as vitritis, when we talk about intermediate or posterior uveitis. So commonly what we do is we look at the inferior periphery, it's an intermediate uveitis, look for snow banking and all. That is okay, but remember that till we have ruled out the posterior involvement, we can't label it as intermediate uveitis. So please rule out retinal and choroidal involvement in the form of doing a good peripheral retinal examination, and only once you have ruled out the retinal and choroidal involvement, you can label it as intermediate uveitis. So again, emphasizing the fact that if you have vitritis, please rule out the peripheral retinal involvement.
I'd just like to add that the color of the lesion that Dr. Nawazish was talking about is basically on your clinical examination, or for that matter on investigations which are true color and not on pseudo color, because pseudo colors might be a little bit more yellowish than normal. So the whiter lesions are one which you see clinically on your examination, and they are the ones which are superficial. So she's highlighted all the points. Just keep this in mind.
So these are very important points. Again, I would like to highlight what also has been mentioned. Once you say it is inflammation and you see a patch, it is very important to decide first whether it is choroiditis or it is retinitis, because your line of management, a line of investigations might immediately change. So like everyone has mentioned, the color, whether it is margins are blurred or not, the more deeper the lesion, the less sharper the margins would be. The more superficial the lesion, the more involvement of the surrounding vasculature and the blurring of the retinal vessels would be. The more superficial the lesion, the more vitritis, chances of vitritis would be there, unless it is an immunocompromised patient, say a CMV patient. So all these things would help you decide whether it's actually primarily a retinal involvement and later on going into the choroid, or whether it is primarily a choroidal involvement later on coming into the retina. If you have any doubt, these days we have a very nice OCT to help you there. If you can get a OCT scan through the lesion, she showed you one scan where you were seeing the choroidal bump with some overlying spillover inflammation just above the retinal pigment epithelium. So that is a primarily choroiditis going into a retinitis. Whereas a primary retinitis would see what appear as the entire retinal layers would become hyperreflective and white, and the choroidal layers would either have shadowing if it is too much white, or you still might have the visibility of the choroidal layers. So that gives you an idea whether it is a chorioretinitis or a retinochoroiditis, in case you're not able to decide just based on your clinical examination. Okay, so I think basics we'll end here and we'll go on to the individual types of retinitis. So I would first invite Dr. Shaurya to tell us about toxoplasma retinitis. Change this talk, please. We've changed the order slightly. Go to the third talk, Dr. Shaurya Azad, toxoplasma retinitis. Dr. Shaurya Azad.
Okay, so I'll be speaking on toxoplasma retinitis. So it is the most common form of posterior uveitis in adults and children, and it is caused by a parasite which is an intracellular obligate parasite, which is Toxoplasma gondii. It most commonly occurs in individuals who are immunocompromised, pregnant women, and also in elderly population. The transmission can be either a vertical or what we say is a congenital transmission, or it can be through ingestion of these cysts that are there from contaminated food or water. It can also occur as a reactivation. Well, in the life cycle, basically the cats are the definitive host, and the humans are intermediate host. It can be infected by all these forms and cysts. So basically we have two forms. One is the congenital form and the other is the acquired form. The congenital form is basically from the vertical transmission, and if the mother is having a toxoplasma infection, as the trimester goes by, the chances of the child having the infection is also, it increases accordingly. And it is basically a retinochoroiditis that is there at the posterior pole, and it is in a wagon wheel sort of a position shape, and it is bilateral. And if you can see, the amount of pigmentation that is there is a little bit more than what you would probably see in a macular coloboma. There is another congenital form, which is basically the Sabin's tetrad, in which apart from the retinochoroiditis, you also see hydrocephalus, intracranial calcifications, and cognitive impairment. Now, these are seen in a very few set of populations. Some of the literature says it's 2%, or some say it is 10%. The other form, which is the more commoner form, is the acquired toxoplasmosis, when the patient might actually land up saying that there's a unilateral blurred vision, or the patient is having floaters. If you see the anterior chamber, you will be seeing some amount of anterior chamber reaction in the form of either granulomatous or even non-granulomatous. The IOP is said to be risen in maybe around about 15-20% of patients, and typically what we see in the fundus is this whitish focal area of retinitis that is there, and you also get some amount of vitritis that is there. It can also be present in the form of a healed lesion that is there, that is the pigmented lesion that you see in the center, and a surrounding area of retinitis that is there, and it is when there is a reactivation. And lastly, it can be a severe form in which you are seeing this headlight in fog. The headlight is basically the area of retinitis that you are seeing by the arrow, and you can also see the disc just little bit on your right side, and what is the haze is basically the vitritis, and if you can see through it, it seems as if you are looking at headlight of a car through the fog. Apart from that, these lesions can also be somewhere near about the disc, and sometimes they can even lead to adjacent disc swelling. So it can be in the form of neuroretinitis, and the typical sort of perivascular sheathing that is there and the exudates that are there, which you can see in this photograph, which are actually called the chiraless arteriolitis. The complications can also be there, that it may lead to a cataract or a macular edema or retinal detachment rarely. Then the other form is basically the atypical form, which occurs in basically immunocompromised individuals, specifically ones who might be on steroids, maybe because of a wrong diagnosis, or maybe immunocompromised by the immune status, or maybe an elderly patient who can have these sort of atypical presentations. So if you can see that what we were talking about is basically a focal lesion, and that also posteriorly, and now you are seeing these large confluent areas of retinitis which are there associated, and there is no scar that is there that you might tell you that it's a reactivation or something, and these patients are typically a differential for ARN. Again, this was another patient in which we had this peripheral retinitis that was there, diffuse. Apart from that, there was arterial involvement. Some parts of it was healing as well, because the patient was already on steroids. However, the patient was not improving, and when you do the lab workup and you see that the IgG levels are high. Another form of atypical is basically the punctate outer retinal toxoplasmosis, in which you get these deeper lesions, and that is the reason why they look a little bit more yellowish, because as we said, as you go down the retina and more towards the choroid, the lesions start becoming from white to off-white to more yellowish. And these can be multifocal. Multifocal doesn't mean that there are multifocal and different too far apart. They are next to each other only, but small yellowish dots, and they can also be a subretinal exudation as well. So to go to diagnosis, basically it's a very classical sort of a lesion, so it's not much actually to ponder on, apart from the times when it is atypical presenting as an atypical form. So typically these retinitis are not associated with hemorrhages and any hard exudates, and on OCT you can see these as a very full thickness hyperreflective disorganized neurosensory retina, and when they heal on treatment, then you can see that the retina actually becomes thinner and some part of it becomes necrotic, and there is clumping of the RPE. So what you need to do basically to confirm, well, a typical form with detection of toxoplasma antibodies, IgG, IgM, you can do them. You can support it with even PCR in cases where you feel that you are not totally sure that it is that. And also you can do the Goldman-Whitmer coefficient, in which it is basically compared by seeing the IgG levels in the serum to the IgG levels in ocular fluids. So if you suspect a case of ocular toxoplasmosis, if you have a typical presentation, you can simply just go do a serology, and if it is positive, you can move on with treating the patient. If it is not, then it might be an immunocompromised patient in which the levels were not significant, and now you can probably go ahead with doing a PCR and confirm it. If it confirms, then again it's a diagnosis. It confirms your diagnosis. If it is negative, you need to go back and reassess whether your suspicion, your differential was right or wrong. In case it is an atypical presentation from the beginning, then obviously if vision at risk, you can do the set of examinations, which is seeing the antibodies as well as seeing the PCR and the Goldman-Whitmer coefficient, and in cases where it is more than 2, then it is considered to be positive. According to the Sun classification, well, it has to have a focal necrotizing retinitis, and it can be either A or B, A being the evidence of infection on the basis of either PCR or antibodies, or B being that there are typical findings like there is a hyperpigmented scar, and from the side of it is basically the lesion that is coming out. They are oval and they are round, and they can also be recurrent. So treatment wise, if you see the literature, classically they used to give a triple therapy in which they had pyrimethamine and sulfadiazine. However, those drugs were associated with some amount of bone marrow suppression as well as hepatotoxicity, and that is why the preferred right now is sulfamethoxazole and trimethoprim, and these are in double strength, so they are either present as Bactrim or Septran DS, and on the third day you add oral steroids to control the inflammation. For the antechamber involvement, you can probably give topical steroids. So as you can see, there was an area of focal retinitis, there was arterial involvement, and on OCT you can see the disorganization and all full thickness layers of retina being involved. And as you see, start the treatment, it starts resolving, the reflectivity is decreasing, the thickness is decreasing, and the area is now being, now there is necrosis that you can see, and it is more pronounced when it is almost complete to hearing. The problem again with these infections is that there is recurrence, so there are chances of almost 30% of the people recurring in 1 year and around 50 around in 2 years. And these are more commonly seen patients who are younger age, who are immunocompromised, and are either pregnant or have undergone a cataract surgery. To summarize, basically they have a very characteristic appearance, so at least in the typical form, it's not a very hard diagnosis to make. What you should be aware of that they recur, so the treatment should be adequate. In atypical cases, you can actually support it with serology, and anti-toxoplasma therapy is basically what we give as Septran or Bactrim, and adjunctive therapy in the form of steroids helps in controlling the inflammation and preventing unwanted outcomes. Thank you.
Thank you so much, Dr. Shaurya. So the main thing to emphasize here is that this is a clinical diagnosis. So once you have that white lesion, and if you also have an adjacent scar, then there's nothing more to add to it. Sometimes the scar may also be in the other eye. So also see the other eye carefully. And if there is also vitritis, again that makes it very confirmatory. So serology is not necessary. Serology may be false positive also. And what he is talking about PCR, that we generally reserve for cases which are atypical. So if you have those large patches which may mimic an ARN, which don't typically look like a focal patch, we have the confusion. Then once we are doing vitreous tap, we send it both for herpes viruses, CMV as well as toxo these days, because some of the cases we have found to have toxo. And another thing I wanted to emphasize was the arterial involvement. So that chirales, please look for it carefully. That is not just a feature of toxoretinitis. Any retinitis we have seen, once it starts resolving, once those vessels start becoming more clearly defined, you can see those exudates on those arteries. We have seen it in CMV, we have seen it in post-fever also. But again, the presence of those chirales arteriolitis means that you are dealing with something like a retinitis. Sometimes a self-resolving retinitis, only sign might be that chirales, and you would know that that patient has a retinitis and now a thin retina over there. So any questions from the audience on the basics and toxo at present? Yeah. But had it gone on to a chorioretinitis, or it was just a chorioretinitis? So Dr. Devesh is saying that even in panuveitis choroiditis you can see chirales, but yes, retinitis typically it's a sign of retinitis. Yeah, please go ahead.
Do you treat the extramacular toxo lesions?
Yeah, so the literature says that if it is an extramacular, it is not vision threatening, you can actually just leave it, it resolves by itself. So it's not required to treat those lesions.
But yes, any lesion close to the arcades or if some lesion is causing vitritis, causing loss of vision, then I would rather treat the lesion. Yeah, but literature, like he said very rightly, might say that you leave it. But once the patient is symptomatic and it's close to the arcade, why do you want the scar to go big? I would rather treat.
Recently, I came across with a case. It was quite far from the macula, but I observed it. After 2 months, it became scar, but it recurred again.
So
then
even with treatment, it can recur because all these therapies are bacteriostatic. But like I said, depending on the size of the lesion, location of the lesion, symptoms of the patient, if it is a small lesion you have decided to observe, fair enough.
I think the important issue in that patient would be to look for immunosuppression. If there is any immunosuppression, then we need to treat it irrespective of the place. But if it is an immunocompetent patient, then we may choose to observe small peripheral lesions.
So before we go on to
About 4 weeks or 28 days, and for the first year the recurrence rate is about 30 to 40%. So can we consider them for a prophylactic therapy for a longer duration of time? Are we doing it?
There is literature that says that you can actually continue the bacterium or septoran for a year to prevent these recurrences. So as prophylaxis.
So there are a lot of articles I think from Brazil where people have given it for
No,
years and years. But fortunately we have not seen so commonly recurrences, or maybe our patients don't regularly come back to us only. But yes, if I have a patient who has had a recurrence, then second time I would like to keep them on low dose for a year at least. So, but if you are having a patient for the first time, it is nicely healed, then I would probably not do.
No, not same dose.
Same or
Half.
Half.
Once or twice take
Once.
Once. No.
I think again it will be important to rule out immunosuppressed state, because if it is the patient is immunosuppressed, you might want to continue it for a longer time.
Before we go on to the next retinitis, we have a keynote talk by Professor Subina Narang, who is head of Chandigarh Medical College Ophthalmology. So Dr. Narang, please. The topic is not related to retinitis, but at least retina. Management of ROP. So can we have Dr.
Hello, good
Subina's
afternoon.
talk, please?
Good afternoon, everybody. I'll take you to the world of preterm babies from amidst the retinitis, taking a little bit of your time. So I don't have the slides. Can I have a pointer, please? At the outset, I would like to thank AIOS, especially Dr. Lalit Verma, for having me here for this talk. I would be talking on management of retinopathy of prematurity. Let the little light shine. These are small little babies. It doesn't move. The slide does not move. It chal nahi raha. Okay. Now it is important because India has highest number of preterm babies to the tune of 3.5 million. And preterms at risk of developing ROP would be around 2 lakh. And there are limited number of ophthalmologists who are involved in treating and screening for retinopathy of prematurity. Thus, India needs to scale up the services of screening and treatment of babies with at risk of retinopathy of prematurity. Now, RBSK has taken this up as one of the diseases where at-risk babies do need universal screening. So all preterm neonates with birth weight less than 2,000 grams and gestational age less than 34 weeks require screening. And this gestational age can increase to less than 36 weeks if risk factors for ROP are present. There are various risk factors for retinopathy of prematurity. This is just smooth, yeah. And in our setup, we found that double volume exchange transfusion is the most common independent risk factors for retinopathy of prematurity. We have to screen these babies in first 4 weeks of postnatal life. And in case your baby is smaller, is less than 28 weeks and less than 1200 grams, then we prepone the screening to 2 to 3 weeks of postnatal age. And it's a famous slogan by Dr. Subhadra Jalali, 30 din roshni ke, easy to remember. And after you screen, you must document this because of the medico-legal issues which are associated with it. We must know what is the extent of the disease, that is which zone it involves, and what is the severity of the disease. Zone comes from, like, zone 1 is twice the, with disc at the center, draw a circle, twice the distance between disc and macula is the radius of the circle. Whatever you see in zone 1 in a busy clinic, take it with a 28 diopter lens. If this is the field of view you are seeing and your disc is touching the rim of the field of view, whatever you are seeing is zone 1. And from the nasal ora serrata, the rim which is there beyond zone 1 is zone 2, and zone 3 is the temporal crescent which is left behind. And you must document what was the postnatal age of the baby and what was the dilatation status and when does the baby come back again with the date of the baby. The severity of ROP depends on, you have to look at the vascular avascular junction. If it is just a small line, it is stage 1, stage 2 when the line gets volume, and stage 3 when there is extraretinal proliferation, neovascular proliferation, and stage 4 is when retina gets detached. And it's not complete detachment. Complete detachment is stage 5 ROP. And lower down there, just the images of fluorescein angiography, which tells you what exactly is happening to arteriovenous shunting, which is happening in stage 1, 2, and 3. This is another thing which we must all know, aggressive retinopathy of prematurity, because this is scarring disease. Here you have flat neovascularization, and the vascular loops are there in zone 1 or posterior zone 2. Here the disease does not grow to, it just straight away progresses to stage 5. It does not go to stage 2, 3, where it doesn't give you time. You have to immediately act and treat these babies. And plus disease is actually dilatation and tortuosity of vessel, and with newer classification it is very clear that it is not plus disease what it was, which is seen in the bottom picture on the right side. It was affecting all 4 quadrants. Now it is continuous spectrum. It could be normal, slightly more tortuosity could be P+, or it could be more than that. And when do we treat these babies? So if the baby plus disease is very important, if you have plus disease in zone 1, all stages you need to treat. If you have stage 3 in zone 1, even without plus disease, you are going to treat. And in zone 2, if it is stage 2 and 3 with plus disease, that requires treatment. And now with tele-screening, which we are doing because of large number of babies which are having ROP, for this tele-screening, you have to identify what are the referral warranted ROPs. If in your picture you have plus disease, you have zone 1 disease, or you have stage 3 or worse disease, these are the babies who require referral. And then they have to be screened time and again till the time either the retina fully vascularizes or the baby goes on to develop the treatment requiring ROP. The treatment is you have to aim at decreasing the VEGF levels, because that is the root cause of getting all this ROP. So what you have to do is either you ablate the avascular retina, which is the cause of all these VEGF levels, or you put anti-VEGF drugs. And then after laser treatment also, ETROP is the largest study which was done here. It shows that you have 15% risk of unfavorable outcomes. Anti-VEGF agents are gaining popularity. More and more people are trying to use it, but mind it, they are the treatment of choice for zone 1 disease. But the outcomes are suboptimal, and they can be used for other cases in case your laser has done and the outcome is suboptimal, or you have poor pupillary dilatation, or you have vitreous hemorrhage, vitreous haze, then you go ahead with treatment of anti-VEGF agent, which has to be with a safer strategy, which most of us know. You have to go along the visual axis of the patient, about 1 to 1.5 millimeter from the limbus. The timing is very important. You have to inject when the VEGF levels are high, that means 32 to 35 weeks of post-gestational age, not before it or not after it. And it has been seen that the single treatment success rates are higher with bevacizumab. However, ranibizumab is FDA approved right now for treatment. And it is seen that laser treatment matches bevacizumab in case you are giving for ROP, all stages. If you are giving for zone 1 ROP, yes, the bevacizumab definitely has advantage over laser treatment. There's a meta-analysis on pharmacotherapy of ROP. Now it makes it very clear, it is like pharmacotherapy is not a one-time treatment. We do get reactivation, and the major problem of vascular arrest is there, especially with retreatment. So you have to be careful while injecting anti-VEGF. We reserve it for zone 1 ROP. Otherwise, laser treatment is highly effective, and there's reduction in retreatment levels also. Now, we usually follow the amalgamation of two. Here you have this zone 1 ROP, the macula is hardly formed here, so you go ahead with anti-VEGF treatment, you let the vessels grow past the macula, and then you could add laser treatment to the peripheral avascular retina, which will be left behind. It just gives you some time till the vessels grow over the macula. Surgery in advanced ROP can be given for stage 4 or stage 5. It is good prognosis is there in stage 4 ROP. However, in stage 5, the prognosis is dismal. In ROP, doing little is a lot, so just cross all the traction bands. That is all you have to cut. Do not aim at removing the hyaloid in these cases. And the story does not end there. It's a long way. ROP babies are friends for life. So they could have other problems like myopia in long term, more incidence of cataract, more incidence of glaucoma. So once you see an ROP baby, lifetime you have to see that baby for other sequelae of ROP. Now this is the long-term follow-up. This is one of the first babies I treated. She came to me with stage 5 ROP. And one eye went into phthisis after buckling. The right eye has ambulatory vision. And this is, she proudly sends me MA political science. And I'm very happy to put this picture here because, yes, we are making a difference in the society. ROP screening requires lifelong association with the baby. It requires dedication, precision, perseverance, and patience. Follow-up preterm babies till the baby is out of danger of developing ROP. Risk of recurrence should be known, and long-term sequelae need lifelong follow-up. Let not an eye go blind. Let their light shine. So, this is small little babies. You have to save them, and everybody has to join hands. All retina people should screen these babies and refer to places where treatment is available. Thank you.
Thank you so much, ma'am. Thank you for such a comprehensive talk. Yes, a very important message. I think all retina specialists should learn this skill, and because if we can save these babies, it's probably much more important than so many other diseases. You are saving a lifetime of blindness over here, and this is a preventable blindness. So really a very important topic, and whomsoever can do it, I would also request, please learn this skill. Little bit hesitation is there to see small babies, but if you can overcome it, it's a very good thing to do. Thank you so much, ma'am. Any questions for ma'am? Yeah, please.
Do you AC tap while giving anti-VEGFs? It's a very small. Yeah. Ma'am, what is the time difference between the anti-VEGF injection and the laser that you do in zone 1?
What we usually do is we let the vessels grow past the macula. Let them cross the macular area, and probably like you would, the time where you are expecting the recurrence, you should see the baby then. So it is roughly around 4 months. You will expect the recurrence to be there. So in case the recurrence is there, normally we do fluorescein angiography also for these babies. That picks up any leakage, or then you go ahead with treatment.
Usually how long it takes for the vessel to regrow past the macular area?
No, it is like you would see the baby when, it depends when you've lasered first or when you've injected first. After that, you maintain on follow-up every 2 weekly.
2 weeks.
And you would see.
Dr. Devesh, you want to add on when to laser in ROP after anti-VEGF?
There are different approaches. So one would be people also laser just along with the anti-VEGF also at 1 week or 2 weeks and combine both the effects, but then you're losing on the benefit of anti-VEGF therapy with that. You should allow the retina to grow beyond the macular area, or maybe zone 2 till the zone 2 posterior area is vascularized, and then maybe wait for the recurrence, or maybe at the high risk interval when it is about to come, maybe 6 to 8 weeks for ranibizumab and 10 to 12 weeks for Avastin, and then you can laser during that time.
So keep following up the baby, let it grow. If you have GA facility, let it grow even more, because the larger the baby, then under LA it won't be possible for you to do. Then you have to do under GA. If you don't have GA facility, then as soon as you feel you are comfortable and like the baby is not going to be uncomfortable doing laser, do it.
What is the interval for a repeat injection for you, sir? Like suppose you inject the baby and you feel after, like you follow it up weekly. So what is the interval for the repeat injection?
So your answer.
I would not go ahead with repeat injections because we've done fluorescein angiography, and we've seen, even Lepore has seen, that even after 4 years, the vessels, there's a halting of growth of vessels. So So the vessel growth absolutely halts after repeated injections. So I usually stick to one injection. I don't know what doctor.
Rarely we go for second injection. Mostly would like to laser it. Yes, Dr. Khosla, you want to add something? For a repeat injection.
And secondly, suppose there's a baby with stage 1 or 2, just stage 1 or 2, no plus. Till how many weeks of post-gestation you follow the baby?
I would follow till, for medical legal issues, you have to really follow till 45 weeks. Even if you see that vessels have reached zone 3, very unlikely that they are going to, recurrence is going to be there or they are going to have treatable ROP. Still, on paper, the documentation has to be 45 weeks to 50 weeks, one follow-up has to be there.
Thank you.
Thank you so much. I think let's come back to inflammation. So now we will have a talk from Dr. Devesh on acute retinal necrosis.
Thank you, sir. So, acute retinal necrosis is a peripheral necrotizing retinitis that has a characteristic appearance and a course which occurs predominantly in immunocompetent patients, and it is caused by HSV or VJV commonly. Now, if we see the epidemiology here, most commonly it occurs because of varicella infection, followed by herpes simplex, and then very rare reports exist of CMV as the etiology for ARN as well. Now, majority of the patients will be immunocompetent here, but rarely again patients who are immunocompromised, such as those with HIV or those on immunosuppressants or with hematological malignancies, could also develop ARN. Now, the ARN which occurs in such immunocompromised patients, it has a different clinical appearance and course as compared to those who are immunocompetent. Males and females, they are equally affected, and now there is a bimodal presentation that happens because of the difference in the etiological agent. So, majority of the cases are about 50 years of age, the median age is around 50 years, and the infection is because of VJV or HSV1. And in younger population, because of HSV2 infection, it can be around 20 to 25 years of age. Now, how does the viral infection reaches the retina? It is not very clear, but it is presumed that it occurs because of a retrograde transmission of the virus from the ganglion which are there. Predominantly, it is considered that it is the ophthalmic divisions of the trigeminal nerve or the maxillary division of the trigeminal nerve. Through that, it comes to the eye. Now, the virus reactivation, it can occur years after the primary infection, which could have been a subclinical infection, or in certain cases it could occur with the systemic infection in the primary setting also, such as those patients who have herpetic encephalitis or dermatomal zoster. In those patients, sometimes you can have primarily viral infection in the eye as well. Now, there are two distinct phases of ARN. In the acute phase, you have virus-induced cytolysis, and that leads to an inflammatory response which damages the retina further. And you also have arteriolitis, and that leads to occlusion of the capillary network, and capillary non-perfusion happens, which then profounds the retinal damage. Now, in the cicatricial stage, what happens? Because of the acute phase, there is a lot of cytokines that are released into the vitreous cavity. Now, these cytokines have an effect on the RP and the fibroblast, and membranes form and they contract. And in addition, there is necrosis of the retina. So, these membranes, they contract and act on these breaks to cause retinal detachment. Now, three cells are predominantly involved here with the infection, and cytolysis affect all of them: the neurons in the retina, the RP layer, and the vascular endothelium. It's a full thickness necrosis that happens in the retina, and there is fibrinoid necrosis in the arterioles as well. Now, coming to the case, a peculiar case in which a 39-year female with no systemic illness presents with a 4-day history of mild pain and some blurring of vision. So, this won't be the usual presentation, but this is how usually the ARN will start with. And the patient had 2+ cells in the anterior chamber with few retrolental cells. If you see the posterior part of the fundus, it more or less seems normal. So, unless you do a dilated examination and inspect the periphery, you are going to miss such cases. When you see the inferior periphery in this patient, you can see there is a confluent patch of retinitis inferiorly, and there are small other patches which are present in the periphery. There is minimal hemorrhage. There is not much vitritis at this time because the presentation is very acute. And you see the other eye is perfectly normal. There is some white without pressure area over here. So the manifestation is mostly it's a pan-uveitis that happens with sudden onset and acute course. Usually it is one eye involvement at presentation in most of the cases, and the fellow eye can be involved if not treated in up to 1/3 of the cases. The progression, as I have told, it begins as if it is an anterior uveitis, but if not treated within 2 weeks' time, the classical triad, which is peripheral retinitis, occlusive vasculitis, and vitritis will happen. The peripheral retinitis has scalloped margins, and retinal hemorrhages are very few. Most likely, you will see patients who will present with this picture in which there is confluent patches of retinitis which are spreading circumferentially with lot of vitritis. So this is a very common presentation. Other common presentation could be an annular involvement in which the presentation is more delayed, lot of vitritis, and the lesions have spread annually, and they are now progressing posteriorly as well. And this is a patient with HIV who had extensive involvement but not much inflammation. Now the diagnosis is till date, till 2021, when Sun gave the diagnostic criteria, revised diagnostic criteria, it was a clinical diagnosis, basically including one or more foci of retinal necrosis with discrete borders in the peripheral retina, rapid progression in the absence of therapy, circumferential spread, occlusive vasculopathy, and prominent inflammation. Now, rapid progression will be noted only on follow-up. So now Sun working group has removed the rapid progression, and it says that any peripheral necrotizing retinitis with either a characteristic appearance and course, or you can have atypical cases in which you may not have a characteristic appearance and course, but still the PCR of these patients could be positive for HSV or VJV. So these will also fall under acute retinal necrosis. Now they have removed the rapid progression, and they have included the use of PCR. Important here that they have included in the diagnostic criteria that positive syphilis serology test is to be considered as an exclusion criteria. Now diagnosis could be supported if there is systemic herpetic infection, and it can be confirmed with the presence of viral DNA either in aqueous or vitreous. Aqueous sample is as good as vitreous, and the positive the sensitivity is as high as 100%. So you get a very good PCR report in such patients. The load is also very good. So, but the PCR, although it is confirmatory, you should not wait for the PCR result to come. You should immediately start the treatment in typical cases. Now differentials, CMV retinitis, will come to that later on. Toxoplasma, we have already told in atypical cases, Dr. Shaurya had shown that atypical cases, you need to look the fellow eye also. There could be some choroiditis scar which could be there, and then on doing the serology, it came out to be a Toxoplasma retinitis. Then syphilis is a great masquerader, and the incidence of syphilitic uveitis and retinitis is on rise post-COVID, and there are lot of cases that could be in the advanced stages, they could be confused with ARN. So this is a typical presentation of syphilis in which you have placoid lesion along with these characteristic punctate inner retinitis lesions which are there, but in advanced cases you will have extensive vitritis along with some retinitis lesions. Now in this state you can confuse it with ARN, and if you treat with antiviral therapy alone with oral steroid, this is likely to worsen with time. So a serology for syphilis should be done in all atypical cases where you are suspecting ARN. Now investigations, normally these are not required, but peripheral OCT, yes, it can help you make out whether it is a full thickness retinal involvement or predominantly outer retinal involvement or retinochoroiditis with hyaloidal thickening that can happen in Toxoplasma retinitis. In late phases, it can help you make out retinal detachments and retinal breaks. And if you see in this case, there are a lot of retinal atrophy which is happening in the periphery, and retinal detachment is there, and there is residual opacification of the retina in between, and adjacent areas are thinned out retina which could be seen in on OCT. The treatment is aimed at treating the affected eye as well as preventing the infection in the fellow eye. So it is important that you timely treat these patients. The classical regimen is that you used to give intravenous acyclovir 10 mg per kg 8 hourly for 10 to 14 days, and that to be followed by oral acyclovir for next 6 weeks to 3 months for preventing infection in the fellow eye. So the induction phase is aimed at treating the affected eye, and the maintenance phase is to prevent infection in the fellow eye. But then there are some modifications, we'll come to that. Anti-inflammatory treatment, oral steroids are very important, and you need to start them 24 to 48 hours after the antiviral therapy has been given, and you see some response of antiviral therapy, then you add prednisolone. And topical steroids in cycloplegic may be required for anterior uveitis. The role of aspirin is very controversial. Some people think that it helps in preventing the occlusive phenomena that happens with arteriolitis. Now, alternative therapies could be in the induction phase. You can use oral valcyclovir, which has a very good bioavailability. 2 grams TDS is equally efficacious to intravenous acyclovir. And alternate maintenance therapy could be oral valcyclovir, 1000 milligram TDS, or maybe once a day for different etiological agents. Now, the bioavailability of these drugs is so good that you need not give intravenous therapy for these patients and need not admit these patients. But then the downside is the cost of these medication, which is very high. The regression, it usually starts from the peripheral edge, and there is some salt pepper pigmentation. So after 8 weeks of treatment, you see that the retinal atrophy has settled, has developed here, the opacification has resolved, and later on breaks can also form in such retina. The slides are not moving. Okay. So this was a case of bilateral ARN, and at 2 weeks the disease has started consolidating, and it's 4 weeks in the left eye you see there is a retinal detachment which has happened, and in after surgery the retina is well settled, and in the right eye at 10 weeks the retinal detachment has happened. So retinal detachment happens in around 75% of the untreated cases mostly between 6 to 12 weeks, and the treatment is aimed at internal surgery with vitrectomy and endolaser and siliconal tamponade. The complication other could be an optic neuropathy that happens in 50% of the cases. Now, prevention of the fellow eye could be done, as I told, by extended antiviral maintenance therapy, and retinal detachment, there is not much proven role, but possible benefits could be with the combined intravitreal therapy and prophetic laser or early vitrectomy. Now, the meta-analysis studies recently published do not support the role of either prophylactic laser or prophylactic vitrectomy, but these are being explored. The downside of these meta-analysis studies that they have mainly concentrated on there are only retrospective cohort studies, there are no prospective controlled trials. To conclude, ARN is a rapidly progressive necrotizing retinitis that is caused by VGV or HSV. It might be overlooked in the early stages and may be mistaken in the late stages. Syphilis remains an important differential, and prompt treatment is required, followed with oral steroids, 24 to 48 hour laser. And retinal detachment commonly occurs in untreated cases and may possibly be prevented with prompt and antiviral therapy along with oral steroids. Thank you.
Thank you so much, Dr. Devesh. So, very nice talk. Just to add, my personal preference for treatment, I now go for 2 gram TDS valcyclovir. I have personally not tried intravitreal ganciclovir, but I have been reading now lot of literature where people say that adding on intravitreal ganciclovir, although ganciclovir more for CMV, but it also acts on this virus because in vitro it has shown activity and it may reduce chance of redetachment. But personally, I have not used it in many cases. Maybe we can try. And role of laser, like he rightly mentioned, we generally say avoid laser, but sometimes when you see those large thin areas and you feel very scared, you take an optos photograph, then sometimes we have added laser. I think he quickly showed that photograph because of lack of time. But if you do laser, please do it in normal retina. Don't do it in the thin retina. You do it at the normal edge and do a wide laser from ora to ora in the normal retina. Don't go and laser the thin retina, either you might create a break. Anything, Dr. Will? Any questions or any comments from the audience? Thank you so much. So, yeah.
From a general ophthalmologist point of view, how long do you continue this valcyclovir for ARN, and how long do you continue the Ceftran DS in cases of toxoplasma?
So for ARN, usually the induction phase is to be ideally be continued till the consolidation of all the lesions is there. So usually that will require 2 maximum 3 weeks of therapy, and sometimes if it doesn't resolve within 3 weeks, then you may continue it for a longer duration also. But the maintenance therapy will again depend on the immune status of the patient. Usually 3 months minimum, because majority of the fellow eye involvement will occur within 3 months, but people have given it for 6 months and up to 1 year as well.
And for toxoplasma?
Toxoplasma, we had already discussed that toxoplasma we might again based on the immune status, but people are giving it for 1 to 2 years also, and they've seen reduced recurrences. But as told by Dr. Rohan, in our setting, we have not seen much recurrences ourselves.
Immunocompetent patients,
So immunocompetent patient, normally in the first go, we do not continue it beyond the routine, but in immune compromised patients, yes, you need to give it for longer or maybe lifelong.
No, we are not routinely using aspirin. No, we are not using. Thank you. Yeah. So now I invite Dr. Vinod for his talk on CMV retinitis.
Good morning, everyone. Rather, good afternoon. So I'll be talking about CMV retinitis. Now, there is only subtle differences between AR and CMV retinitis, and once you are new in the field, you might confuse between the two. I'll be showing you a few cases. The idea is just to make you recognize that how these two differ from each other. As compared to some other viruses, CMV or cytomegalovirus is a ubiquitous virus. It is seen in approximately 40% of the normal population. And usually most of us would have this virus in the eye in a latent form. Now, once a person is immunocompromised, this CMV virus gets activated. It acts as an opportunistic infection. While typically we had seen CMV retinitis, lots of them with AIDS and HIV, but with antiretroviral therapy now prevalent, this incidence of CMV retinitis in these cases on the decline. However, the other immunocompromised states, for example, chemotherapy, organ transplant patients, and even the patients who have been on steroids, it's not uncommon to see CMV retinitis in these cases. In fact, it is again, remember, any immunocompromised state, you must think of CMV retinitis and not only AIDS. So typically, again, CMV retinitis usually would start in the periphery, especially the one which is in the indolent form. So these patients can be asymptomatic, or they may present with floaters because of vitritis. Sometimes because of inflammation, there might be mechanical stimulation or chemical stimulation of photoreceptors, and these patients can present with flashes as well. And of course, once there is involvement of the posterior pole or there is significant haze in the vitreous, the patients can present with blurred or decreased vision as well. Very rarely what will happen is a patient who does not come across any of these symptoms can develop retinal detachment, and then patient can develop present with sudden onset loss of vision as well. And if there is involvement of the posterior pole in terms of macula or optic nerve, the patient can present with markedly decreased vision. Now, have a look at this particular patient. He presented to us with decrease of vision in the left eye for past 1 week. But when we examined him, you can see there's a large area of retinitis, not only in this eye, but also in this eye. So you can see there is active granular form of retinitis which is there. It is healed, but the macula is normal. So patient never got to know whether he had something. But once he developed retinal detachment in the left eye, he presented to us, and at that time we noticed that patient had CMV retinitis, and this patient subsequently underwent surgery in the left eye along with oral valganciclovir therapy. So remember, as compared to ARN, here we give valganciclovir as compared to valacyclovir. So dose is 900 milligram BD typically for 2 to 4 weeks till retinitis heals, and once the retinitis heals, you can shift to maintenance dose 900 milligram OD. Now remember, as compared to ARN, typically CMV retinitis will happen in immunocompromised status. So you need to continue the antiviral therapy till the patient is immunocompetent once again, whereby the patient's immune system is able to fight the CMV virus. Otherwise, it will keep on recurring the disease. And in this patient, in fact, RD was a boon for the patient. Otherwise, he could have presented later on when the macula and optic nerve atrophy. So this is another patient. If you see, there is large involvement of the periphery, almost reaching up to the posterior pole in the right eye. And this patient again treated with valganciclovir therapy, and you can see there's nice healing. This is the typical pattern of healing. It leaves behind some amount of pigmentation, and there would be some areas of granularity which will resolve slowly. This is the other eye of the same patient. You can see there is granular form which is limited to the periphery, and once you treat these patients, they can heal very nicely, leaving the posterior pole intact. But as I said, remember, these patients need long-term therapy. This is the second form of CMV retinitis, where you can see there is more aggressive disease, more posterior disease, and much more hemorrhages. And once it happens at the posterior pole, you can see that it eats up the macula, it destroys the optic nerve, and these patients can present with very poor vision. So this is how it heals. You can see, though the disease has healed nicely after therapy, but the macula and optic disc both are destroyed, and the visual prognosis remains poor in these patients. So again, and this is the other eye of the patient. You can see there's extensive peripheral healing along with activity at the edges. So this is a typical pattern whereby the peripheral healing keeps on happening and the new activity starts, and slowly it progresses to the posterior pole, and if not treated, it can eventually lead to destruction of the macula and the optic nerve. So this patient in fact had RD, and this patient underwent surgery, thereby leading to attachment of the retina, and we could preserve some ambulatory vision in the left eye. So that these were most of the HIV patients, but remember, aggressive form of disease can present in other forms of immunosuppression. For example, this young male with acute lymphoblastic leukemia here, a typical appearance where there is a pizza pie appearance with retinitis, lots of hemorrhages, and these diseases are actually very difficult to control. This patient received not only oral Valgan but also intravitreal Valgan cyclovir. You can see there is healing at the center of the lesion, but the lesion has become larger. The main issue is that these patients are sick. Sometimes they are not able to continue Valgan therapy, and this retinitis keeps on progressing. So you can see there is central healing which is happening, but the lesion is becoming eventually bigger and bigger. And this is on OCT. You can see there is a full thickness macular retinal involvement, which leads to destruction and eventually thinning, leading to loss of vision. So this is the other eye of the same patient. You can see at the beginning there were few hemorrhages, some granular form here, but eventually again, because these patients are not very regular with therapy, you can see the disease becomes aggressive. There is severe disease which involves the macula, and you can see how the peripheral retina has healed, and now there is activity at along the whole edge of the previously healed retina. So this is the follow-up. This patient was eventually, that is what we could spare at the end of the therapy. By the time patient completed chemotherapy for his leukemia, this is what we were left with. So remember, this is how zones are described. Typically you have zone 3 and zone 2 disease, which is milder, but when it is happening in zone 1, it tends to be more progressive. So sometimes the patient can present with picture like this. You can see not only the retina is affected, all the vessels are affected, and this is what is known as frosted branch meningitis. And since many of time these patients are systemic malignancies, blood dyscrasias, you can confuse these with leukemic infiltrates. So whenever you have patient with hematological malignancies, please be very careful that you are not dealing with a case of CMV retinitis. Some other presentation, this patient again, one of the patients with SLE who had who was on steroid for long term, had a papillary CMV retinitis. In fact, this patient we planned for starting therapy, and the patient came very next day, and the patient had developed occlusion of combined occlusion of central retinal artery and central retinal vein. So again, a patient with posterior aggressive disease. Patient was on treatment, and next time when he came, he had appearance of frosted branch meningitis. Since the patient was already on treatment, we did not do anything extra, and this patient eventually resolved. A very aggressive disease sometimes can happen like this, and which can destroy whole of the posterior pole. On the other hand, another patient, you can see mild peripheral disease which heals. So This is in fact the right eye of the patient when he presented, and this is the left eye, only small lesion. Again a patient with hematological malignancies. You can see he heals, but again comes back. Again activity, heals, again slowly keeps on progressing. You can see how it is progressing slowly, and this patient in fact had a very severe kind of hematological malignancy, and by the time his chemotherapy was over, we are left with this, where CMV has destroyed virtually everything in the retina. So as I mentioned, diagnosis is mainly clinical. We typically use valganciclovir in the doses I mentioned, but remember, till immune recovery, you need to continue the maintenance phase. For HIV, we typically say CD4 counts of 200 to 400, but again that is controversial. As mentioned, laser for the prevention of RD is controversial. Typically, most of the cases do respond to valganciclovir, but at times you may require cidofovir and foscarnet, which I don't have any experience with. Earlier, ganciclovir implant was available, but that has been discontinued because the CMV incidence has declined recently. And you need to correct the underlying immunosuppression for the long-term betterment of the patient. Thank you very much.
Thank you, Dr. Vinod, such a wonderful collection of cases. So just to summarize a few things. So as to differentiate between ARN, since CMV comes through the endothelium, there is more incidence of hemorrhages there. Like he showed you, the classic pattern would be a pizza pie, hemorrhages also there. Although you have the granular form also, where you may not have so many hemorrhages, and the vascular form, the frosted branchitis, which he showed you. And if you would have noticed in the white patches that it showed you, most of them had some satellite white granular small lesions adjacent to it. That also is very typical of this CMV. And since these patients are immunocompromised, they don't throw up an immune response. Most of them you will not find significant vitritis. You will just find some AC cells and RL cells, but obvious gross vitritis you will not find in these cases. And regarding therapy, is nicely mentioned, valganciclovir is a very magical drug these days. But for a zone 1 disease, I would augment it. I would give an intravitreal, now a high dose ganciclovir. Earlier we were giving 2 milligram. Now we give 6 milligram, which can be given once a week rather than twice a week. So if it's a zone 1 disease, I would be a little more aggressive in treating and augment it with intravitreal therapy. Any other questions or comments? Yeah, Dr. Divya.
Sir, should we screen immunosuppressed people regularly for CMV retinitis? Because sometimes the patients who are on long-term hematological malignancies, they show up with, you have shown that small granular form of CMV retinitis isolated in the periphery.
I think that's a very interesting question because many of these patients are sick and actually are not able to report. But I don't think offhand there are any study which reports such kind of screening in hematological malignancies.
Sir, I have visited few hospitals just for screening for ruling out papilledema, and incidentally I found these localized CMV retinitis patients in those cases, sir. So I would just as a query I asked.
Yeah, I think it's a very valid question, but the thing is, moment these patients have, as I showed, they keep on having ups and downs of the disease waxes and wanes. So moment they become immunocompetent again, their immune system becomes better, the CMV automatically tends to decline on its own. So that is a big plus in these patients. So with that, I would like to invite Dr. Rohan. He is professor at RP Center. He needs no introduction, and he being a chief instructor would be talking on the posterior pole retinitis. He has very nice way of classifying and identifying posterior pole retinitis. Let's hear to him.
Hello. Yeah. Thank you, Dr. Vinod. So we have now seen some large areas of retinitis which have been explained, which have been categorized into ARN or CMV. So sometimes we see smaller patches, and sometimes some of these are concentrated on the posterior pole. Shaurya touched on a bit of them. So I would like to just again touch on these patients who have these white patches at the posterior pole, which we call as posterior focal retinitis, and how would you on a clinical examination try to differentiate and empirically decide what category this falls into, what empirical therapy should I start before, if at all, I want to do a further PCR or an serology which might confirm the diagnosis. So what I'm going to talk about is we have had a lot of publications on this. So like I said, it can have multiple etiologies. It could be viral, it could be bacterial, it could be toxoplasma. It could even be non-infective, though although rare. But since they are at the posterior pole, they are vision threatening, and one needs to start this empirical therapy before we can get confirmation from some of the laboratory investigation. So you see one lesion right here, you see another lesion here, and the third lesion here. So all three of these had signs of inflammation in the eye, so we were thinking on lines of retinitis, but they don't look alike. So are they the same organism, or by the look can we tell something about what is causing this retinitis? So the first one was very typical, again same photograph with Dr. Shaurya. You see this focal retinitis. Rarely would you see some hemorrhages. In this patient there is a sort of hemorrhage, but sometimes few hemorrhages can be there. But again the very typical same thing, if there is adjacent scar, if there is a vitritis, it's a fluffy sort of white lesion. So that fluffiness in that nature is over there. Disc edema may or may not be there, but sometimes the exudation may be significant. You can also have an exudative RD associated, and again in the OCT you would see that full thickness involvement of the retina progressing towards the choroid. And now some people in toxo also have described, if you see this detached layer of hyaloid, so under this detached layer of hyaloid, the pointer is not coming, can you give me a pointer? So under that detached layer of hyaloid, focal thickening, if there is, are seen with retinitis, people have ascribed it to toxoplasma again. Okay, so under this hyaloid, if you see these focal areas of thickening, so that again sometimes with this white area, people have talked about as toxoplasma. So as discussed, in all these infective retinitis, withhold your steroids at day 1. At day 1, please start whatever antiviral or anti-infective therapy you are planning to give. So start the sulfamethoxam, trimethoprim, wait for 48 to 72 hours, and then start steroids. That will be more helpful. As we have learned from COVID, day 1, if you are starting in the stage of the multiplication of the microorganism, then that is harmful. So let the stage of multiplication die out a little bit with your anti-infective therapy, then add the steroids to help the inflammatory component. And the alternative therapy, nowadays people are also giving intravitreal clindamycin, which can be given once a week in some of the very posterior pole sort of lesions. So again this same sort of patient, you start getting this clearing once you start getting more of this necrosis. So only this ILM sort of draping here, full thickness retinitis. And again you see, since it is going to the choroid, this choroid hump is also now started developing over there. Another one, the focal type of lesion without much vitritis, but again because it's initially retinitis, we treated on basis of toxo itself. Now this patient here, when I saw this lesion, it may be not so much clear here, but I thought it's a very deeper lesion. I thought it's probably a choroiditis rather than a retinitis, but the patient had only minimal symptoms. The patient did not look very, looked a little sick. So the only investigations, and then I did a OCT scan through this, and the OCT told me no, it's not a primary choroiditis by the fuzzy margins, whatever the wrong look impression I was getting, it is rather a retinitis. So a retinitis with not a very healthy looking patient. I just did 2 investigations, and the patient came out to be HIV positive and toxo IgG positive. We treated with anti-toxotherapy, and now you see you've got that scar over here, full thickness scar. Okay, so the second is a viral retinitis. This I have sort of seen, these are white stuck on plaque like lesions, unlike the fluffy lesion which I showed you earlier, and these progress faster, causing schisis, and these also, once the schisis is occurring, the vessels in the inner retinal layers start getting disrupted, and so you start getting these hemorrhages. And some of these patients might give you some other symptoms, like one young patient I saw while we were doing the imaging, threw a fit in the clinic itself, had a convulsion, and we then did an MRI and they had a temporal lobe lesion. So some of them can have these systemic features as well. So this was a young girl, we were initially thinking on a vascular occlusion sort of thing, but there were signs of inflammation. You can see even on the OCT, just below the highlight, you can see these cells over there. And so this patient was initially given IV steroids outside, worsened significantly, but we could see it's flared up slowly under our visualization, developed break, developed a detachment. This eye was lost, but since we had started antivirals, perhaps we could preserve the other eye, although a lot of thinning, but we could preserve at least 6/60 in the other eye. So this is the another young boy. See, this is more of a plaque. This is not that fluffy nature in that, and these hemorrhages there, and you can see this thinning, necrosis, schisis all developing in the OCT. This is another young patient with that plaque. I again thought it is herpes, but on detailed neurological examination and even a biopsy from the brain revealed something else. It revealed a simian virus. Now talking of what I've talked about, if you see this lesion, what would you say? Would you call this fluffy white with some hemorrhages? Would you call this toxo or would you call it viral? So then nothing in medicine is sacrosanct. You take history. This patient gave history of immunocompromised status, and this on actually aqueous PCR came out to be CMV. So you can always have some exceptions. So so this patient was treated with CMV therapy. Initially it worsened. We were a little scared, but slowly it settled down, and the patient also again had 624. So this is the third type, which mimics sometimes like hypertensive retinopathy, but again signs of inflammation on clinical as well as OCT. You see a neurosensory detachment, you see white focal thickened areas. Now this is something called a post-fever retinitis. Etiologies can be multiple. It can range from rickettsia, Lyme's disease to West Nile virus to many other things. So, but these patients I like to treat empirically with doxycycline, because at least some of these bacteria do respond, and they respond very well. Some cases I have seen we did not even have to add steroids. But yes, start doxycycline initially. So this can be due to various etiologies. Start doxycycline, and if at all the NSD is not settling, the edema is not settling by about 3-4 days, then you can add on your steroids and continue the doxycycline for about a month, and slowly you can taper off the steroids. Very rarely, with some cases where the edema I had seen was about 1000 microns or 800 microns, I have even injected Avastin just for a quick response. But the main therapy would remain Avastin, doxycycline. And just to show you some cases after therapy, some of them have shown a very nice resolution, and many of them have recovered even 6/12, 6/9 vision. See, very nice resolution is seen. Slowly those hard exudates and all also would go away. So we had done an analysis of these cases with serology also. Now I've stopped doing serology because probably my therapy doesn't change by that. But if you are doing a study or something, good idea to do. Some of them will come out positive for rickettsia and Lyme's disease. So now just to again leave you with this case, what do you think would this patient, this lesion would be? Would it be toxo? Would it be post-fever? Would it be herpetic? Or would it be CMV? CMV. Okay, so again, history taking has to be there. You have to see the patient in total. This patient was carrying a record of hypopion and uveitis recorded. So this patient is diffusely leaking everywhere. It was more of a Behçet's focal retinitis. In this patient, we just treated with oral steroids. Okay, so that also can be, should be in the back of your mind. So the broad categories, first I would say toxoplasma, everyone should know what it is. Second, there is a flat plaque-like lesion, it could be viral. Third, if it is a history of fever is there, history of rash is there, or you are seeing something like multiple cotton wool spots with inflammation in the eye, it comes in this category. Or rarely, yes, do not miss out the other histories of oral ulcers or some other signs like a hypopion uveitis. It could be Behçet's disease. But whatever it is, when you think it is retinitis, please avoid initiating therapy with steroids. Start one of the anti-infectives first, and then after a few days go on to add steroids. Thank you. Thank you so much.
Thank you, sir. I think one general rule which we all can follow is that by and large all retinitis are infective predominantly. On the other hand, all choroiditis are usually non-infective. So that is a general dictum. It is not always applicable, but once you think of retinitis, please rule out infectious agents and then think of adding steroids and vice versa. So are there any questions or comments? So I think we can start with the second part of this instruction course, where we'll have two small talks about how to manage these cases when they have a retinal detachment.
Thank you. Yeah, so the most dreaded complication here is a retinal detachment, and despite your therapy, some of your patients are eventually going to land up with that. I think this is the other one, Dr. Vinod's presentation. Can I have my presentation first?
Please put on Dr. Rohan's.
The file is number 2. Number 2, Dr. Rohan Chawla. Just put that on. Yeah, thank you. So if you do have a patient with a detachment here, it's not at all easy to manage. But just from some of our experience, we'll share some of the surgical tips I would go ahead with some of my cases, and then Dr. Vinod would add on some tips to that. Okay, so this patient had initially this peripheral lesion with vitritis. We diagnosed as acute retinal necrosis and planned the same way as we have described. We started IV acyclovir and started Vicelon. Patient started improving, but then detached. So then what we planned is, in many of these cases, I generally prefer to put an encerclage, because many times you are not able to remove all of the peripheral vitreous, and then vitreoretinal surgery under silicone oil. So just to show you this surgical video. So these patients tend to develop these large necrotic breaks, and then these areas of traction and some folds. So you have to clear the vitreous over it, and the vitreous is also like not a very normal vitreous, and it can also be shitic. So you have to remove that last layer of shitic vitreous, and nowadays I also stain with BBG and try to remove the ILM over there, so that you are very sure that you have removed the vitreous or any membrane. And at the edge of the break, the breaks there, you tend to form these folds, or this the break is turning over. So there also you have that membrane. So it is a good idea to try to peel that sheet of membrane and try to make that area as traction free as possible and as flat. And then you can also peel the ILM at the posterior pole and drain from those holes. If required, make a separate retinotomy. Otherwise, you can just drain from that and do a very, very broad laser. So the main thing is that the vitreous is again inflamed, so not a very normal vitreous. Remove it as far as possible. It is shitic. Look for the posterior second layer of vitreous. Do a PV triamcinolone staining. Do an ILM staining. Remove that last layer. Remove the ILM at the posterior pole. Extend that ILM. Peel up to the edge of these large breaks. Try to unroll that edge of the break, and that would release the maximum traction. And then drain and do a very, very broad laser and inject silicone oil. In this patient, we were able to remove silicone oil eventually. This is with photograph with silicone oil in C2, but okay, the last photograph is not there, but we were able to remove silicone oil, and now the patient is one-eyed but maintains 6/60. So this is a young boy with ALL, and again you see these large necrotic breaks over there, and some of them forming folds. So that layer of vitreous which still sticks on despite removing the main core of vitreous, you need to remove that, and you need to stain, and more ILM you remove, you make the retina more mobile. And you see again here that at the edge of the break where the rolling is there, if I can peel off the ILM over there, I'm quite sure I have removed whatever membrane is causing traction and causing that break to remain open. So that has probably increased the success of my surgery and increased the chances of removal of oil and still not landing up with a redetachment. So you do that. You see that rolled edge needs to be taken care of. Here these folds are there, retina is sticking on. So do a cautery and increase the size of the retinotomy. You anyway have such large break. You do a retinectomy over there. You have to have a retina which is not under traction, and then go ahead with that broad laser and inject silicone oil. Even in this eye, I was able to remove silicone oil, and this boy developed detachment in the other eye also, which we caught a little early and did a surgery, and we were able to salvage vision in both the eyes. So this is a very advanced case where the small boy had developed this detachment, and despite therapy, patient had a lot of inflammation and lot of subretinal changes had developed. See, a lot of these membranes in the periphery we tried to peel. Unless we remove as much traction as possible, you are going to land up with a redetachment. And here I felt that the whole choroid itself had been dragged posteriorly. There were large subretinal, even bands and sheets of subretinal membranes, where I had to remove them through making some retinotomies. This was a band just next to the fovea. I had to make a retinotomy just close to the fovea. I'm doing this aggressive surgery just because this was the only eye of the patient. Otherwise, maybe you could also have just left it. But those subretinal bands were removed. You can see them better in retro. But still, I felt that the retina is not very mobile. So I tried to inject PFCL, but that PFCL went subretinal. So that means the traction is still not totally resolved. You remove that PFCL, and still if the retina is not fully mobile, you are not left with anything. You have to continue removing traction. See, it's such a large sheet coming out from under the retina, and once this large sheet came out, the retina became mobile. But now anyway the peripheral retina was in tatters, so better I complete the 360 retinectomy. So I did a 360 retinectomy, and finally we landed up with only a small central island, but that's what we could do. But you see that small central island is now fully free of traction, and we just removed the blood, put PFCL. I left this patient under PFCL, and after 10 days removed the PFCL, put in silicone oil, and again in this patient we were able to salvage some vision. So early versus late is controversial. I am a little not a very aggressive surgeon, so I probably don't believe that much in that. But yes, vitrectomy is required once the detachment is there. The vitreous is tenacious. I use an encircling band. The chysis has to be handled. You have to handle the membranes at the edge of the break, the ILM at the edge of the break, and severe cases like I just showed you can have a lot of subretinal proliferation, which you need to manage and do a very, very broad laser. And some of the cases, yes, we will be able to successfully remove oil, and yet the patient will maintain vision. Thank you. Thank you so much. Now I would request Dr. Vinod also to add some surgical tips. Thank you.
So to continue the surgical management of retinitis, I'll just add in a few general takeaway points. So one, RD is a common occurrence after retinitis. So whenever you have a patient of retinitis who suddenly develops decrease of vision, please look at them carefully. So what happens in these patients is there is peripheral retina is plastered because it's heel retinitis. So the central retina would not be very bullous. So it's a very shallow detachment usually, and you may miss initially. So do not miss that. Second issue is that there are lots of, as Dr. Rohan showed, there are lots of holes in the atrophic necrotic retina. Now once they do happen, what happens, overlying vitreous becomes membranous, and it is very tenaciously attached to the retina. So once that happens, it can lead to rhegmatogenous RD, tractional RD, or even a combined retinal detachment. Progressive outer retinal necrosis fortunately is not very common, but remember RD is more common in ARN followed by CMV, and least common in toxoplasma, and once it happens it causes severe vision loss. So before we go to surgery, remember there are some preoperative consideration, whether retinitis is active or not. Now if retinitis is active, please do continue your antivirals. So that is first thing. Do not forget about immunosuppression. So patient comes with HIV, with CMV-RD, please start ART before you start the surgery. See that patient is comprehensively taken care of, screen the partner and the patient for other STDs. And once you are doing surgery, please, we have to be careful of our safety also. So please use all universal precautions with proper waste disposable. And preferably in our setup, we like to do these cases at the last case so that the OT can be cleaned after that. Now some intraoperative considerations are that there is thin friable atrophic retina in the healed area, so which may appear scarred, but please do not pull on to that. It can cause breaks in the attached healed retina. Now that will be a very difficult thing to tackle because there is already scarring there. Once there is break, it starts to get lift up. It would be difficult to induce a retinopexy. Second is, as Dr. Rohan showed, the vitreous tends to be membranous with multiple layers. So that is okay, we can take care of that. We are used to handling multiple layers of vitreous, not in myopia and diabetes. But additional problem here is that it is very adherent, and where it is adherent, it is specially adherent at the edge of the healed and normal retina. Now that is our watershed zone. We don't want to do induced traction anterior to that, but at the same time the maximum adherence is at the point, at that particular point. So we have to be very careful about this particular fact. So I would like to put it in this way. In fact, this junction of healthy and necrotic retina is new retina, new ora serrata, but it is a weak one. So we take our ora serrata as the strongest attachment, but remember here it is a weak ora. Lastly, because there has been previous inflammation, there is poor blood ocular barrier, and these eyes are very prone to PVR even with mildest of intraocular manipulations. So you can do anything 27 to 25 gauge. We prefer 25 gauge because there are many tough membranes which may not be amenable to 27 gauge. As Dr. Rohan mentioned, thorough vitrectomy is required, but if there is peripheral lot of heel retina, you may not need to do anything to the lens. But if there is involvement of the peripheral retina which is there, you need to do base shave, then you will need to sacrifice the lens. If there is active retinitis, please avoid triamcinolone, as residual triamcinolone may affect the disease course. As I mentioned, there's no traction should be there at the edge of healed and necrotic retina. As Dr. Rohan mentioned, a broad laser has to be there. 2 rows of retinal laser we normally do in a break do not suffice here. So you need to give 4 to 5 layers as we give in a case of GRT. And even if even in cleanest of the cases where you think you can get away easily, please do not leave the eye under gas, because these eyes are very prone to PVR. So oil is the tamponade of choice in most of these cases. So I'll just show you one case quickly. So this is a patient with CMV CMV retinitis with retinal detachment. As Dr. Rohan showed, there is vitreous which is quite membranous, but in this patient I was able to induce PVD. So you can see the vitreous is quite hazy, and that is a boon in a way. You do not need triamcinolone, and it becomes membranous. As you can see, there are some membrane. So once you do the core vitrectomy, so the second challenge comes is that these eyes tend to have a very gel-like vitreous which is there. So if you catch these cases earlier, the membranes are not yet found, but there is jelly-like vitreous, and you can see there are multiple breaks here. You need to get all the vitreous of these places, and since the underlying retina is very necrotic and thinned out, you need to be very gentle before you can pull these cases. So you can see this is a healthy retina, necrotic retina. There are membranes. You just need to be very carefully go near the surface of the retina and tease off these membrane and cut off. So there are large breaks here in the superior retina, fortunately for me in this particular patient. So you can use these holes, necrotic holes, for fluid air exchange, and once you have gone through that, you need to apply wide laser 4 to 5 layers all along 360-degree. Again, this is not a choice here. You need to laser in 360-degree. You can see here I am giving 4 to 5 rows of laser, and that would be continued all around. Now in this particular patient there was a challenge because the retinitis in the infratemporal part was just approaching the arcade, but still I was able to you can see here it's reaching up till the arcade. So what I am doing is laser partly in the necrotic retina, but you need to extend your laser into the healthy retina so that it can hold on. So we laser it all around and put oil. So this is the patient I showed you earlier in my presentation. So this is how he had a RD, and after the retinal detachment surgery, you can see it has been lasered 4 to 5 rows of laser, and macula is fortunately preserved in this particular patient. Thank you very much.
Thank you, Dr. Vinod. Any questions? Okay, thank you so much for attending this instruction course. I hope you gained something from it. Thank you. Thank you. Yeah. Sorry, there is one question. Yeah, so encerclage probably again has become a surgeon's preference. So if you are believe in encerclage, you will put an encerclage. If you don't believe in encerclage, you will avoid. So that depends. If it's a very localized RD, then you can go ahead with the. So you're talking about prophylactic buckle. That would be a broader indent, but would it actually help? I don't know, because you, again at the edge of the buckle you can get the break. So I don't. What would you say?
It really depends on how much is the area of involvement in the periphery. So if it is a small one, just area, you can sport that area, but there is no guarantee that this retinitis is not going to progress further, and then you can't keep on extending this thing. And especially in HIV positive patients, I think there's a bit of issue, because one would not want to go in with opening the conjunctiva, and there are more chances of splashes and all those things. So there are issues, and once you have a wide strip of peripheral retina which is already necrotic and scarred, I think it will not make much of difference even if you put band. Hanji Dev.
Sir, I have some query about post-fever retinitis. Sir, post-fever retinitis, have you seen cases of recurrence of CME after initial resolution of post-fever retinitis?
Recurrence of CME?
Yes, sir.
Not really, and actually we are working with Dr. From Shankar Netral, Dr. Ankush. So he also has a very large series on this. So we're trying to make a diagnostic criteria. In that we have put one of the diagnostic criteria as absence of recurrence after therapy. So it's an absolute treatment, because we consider it to be sort of an infection which has gone away after treatment. So absence of recurrence is one of, we are adding it as a criteria for diagnosing post-fever retinitis.
So generally it does not occur.
Doesn't occur.
And sir, secondly, as you have said, sir, means wide rows of laser. So how do we prevent then break formation in the healthy retina if vitreous? Sometimes the vitreous gets attached to that retina, and then if we laser that area, there are chances of break formation due to that vitreous contraction over the retina, sir.
One has to ensure that we need to remove all the vitreous. So if there are multiple sheets, so you need to go till the last one, and what you can do is when you reach so-called weak aura, so what you can do is you can give circumferential relaxations, so that it does not contract in the vitreous, not in the retina.
Yes, sir. Yes, sir.
Circumferential.
I would also like to thank all my fellow speakers for contributing to this session. Thank you so much. Thank you. Okay, please, we can have a group photograph. So we were initially going only with the oral, but now again, if you say if it's a zone 1 disease close within the arcades, probably no harm. You can give one intravitreal clindamycin and simultaneously continue that. Just to be aggressive, I want the infection to go away very fast. But whether I give the second clinda or third clinda, I have rarely given more than one. Although I think PGI group, they recommend giving more than one. And again, how frequently you will give, it's a controversy, because it's a toxic drug. So some people give after 72 hours, but some people say wait for 1 week at least before repeating the second. So what you can do is give one, add sulfa, most of them will respond. No, if it's responding to your oral therapy, then why do you need to give?